need to do is identify disease manifestations. Basically just talking to the patient, examining the patient, then getting laboratory, one can make a list. The first thing that needs to be done after making that list is distinguish activity from chronicity. Perfect example is what I just mentioned. So is a rash that someone has active and potentially reversible, or is it a scar? Another example, if someone has protein in their urine, say from kidney disease, does that mean they have active kidney disease, or is that protein excretion from an episode in years past that's left them with a little bit of scar? And again, you could bombard that patient with a ton of steroids or whatever medicine, and that proteinuria may not go away. And sometimes it's easier said than done to distinguish activity from chronicity, but it's key that you formulate an idea about that. And then the last thing is you prioritize the list of active disease manifestations. That is, what bothers the physician the most? Is it the rash? Is it the arthritis? Is it the kidney disease? And generally, if you target the most active, severe manifestation, the lesser manifestations will come under control. Remember that disease activity is a continuum, and it's very hard convincing our emergency room doctors of this. Any patient with lupus that comes into our emergency room, no matter what their complaints are, ends up getting a very high dose of intravenous steroids. They could have a little bit of rash, high-dose steroids. They could have a little bit of arthritis, high-dose steroids. They have kidney disease, high-dose steroids. So disease activity is a continuum, and treatment has to be tailored to that amount of disease activity. So the bottom line is use the least toxic medicine and the lowest dose to treat the most concerning disease manifestation, and assume that the less concerning manifestations will come under control. And we wouldn't be having this discussion if it weren't for the toxicities of our potent agents that we use. Shown in a graphic way, let's say this is the body. This box represents a normally functioning body. Those are normal tissues. But then all of a sudden a pathologic process develops. In this situation, lupus. So lupus is this black box there. Well, we have medicines at our disposal, immunosuppressives like azathioprine, Imuran or Cellcept. We have steroids. And when you use something like steroids or an immunosuppressive, it's not particularly targeted versus the desired therapy, which would be highly targeted. So what happens is, though you're trying to target this black box with immunosuppressives and steroids, you end up invading and affecting the normal tissues over here on the left, whereas with very targeted therapy over here on the right, you may just be able to focus in on the disease itself and leave everything else in working order. So on the right-hand side is what we desire. On the left-hand side is what we're actually doing. Now there are a lot of different therapeutic approaches in lupus, and I'm just going to talk about drugs. But as you know, we rely on the help of many other types of health professionals, occupational therapists, physical therapists, many other types of physician subspecialists, psychologists and social workers, and the list goes on. So it's really a multidisciplinary approach. But I'm just going to talk about some of these drugs. And for patients with very mild disease, with joint pain, we might just be able to use analgesics. So what is an analgesic? It's a pain reliever, like Tylenol. Sometimes we use topical therapies. For example, topical steroids for rashes. There are some anti-inflammatory gels out, like Voltaren gel that you can put on your knees if they're hurting. Anti-inflammatories, and there's a ton of those out there. Anti-malarial drugs like Plaquenil, brand name for a hydroxychloroquine. The current feeling now is that every lupus patient should be on Plaquenil, not because it's a real potent medicine. In fact, it's not a very potent medicine, but it does a lot of different good things for the patient. Steroids remain the mainstay of therapy for lupus. Antimetabolites refers to drugs like azathioprine, Imuran, mycophenolate, Cellcept, methotrexate. And then there's chemotherapy like cyclophosphamide, Cytoxan. And now we can talk about biologics, and more about that later. So let me just talk about the toxicities. Hydroxychloroquine, I just said every lupus patient should be on that. It can cause ocular disease. So as soon as you mention eye disease to a patient, they get turned off about going on this particular type of medicine. It can deposit in the cornea, which is of no clinical significance. But what we really are concerned about when it deposits in the macula, which is in the retina, and if it deposits there, you can lose vision. It's a very rare side effect, but we still send patients to the ophthalmologist for checkups. Steroids, the mainstay of therapy. And I can't imagine what it was like to be interested in arthritis and rheumatology back before 1948. What happened in 1948 at the Mayo Clinic is that the first patients with rheumatoid arthritis were treated with steroids. And you can find is a video showing these patients who are crippled, bedbound, and then they're given prednisone, cortisone, and all of a sudden they're out of bed and they're walking. So with steroids we've made major inroads, but there are toxicities with steroids, and I've listed some of them. High blood pressure, the moon face, which no one likes, osteonecrosis, which I showed you on the x-ray, that's death of bone. Sugars can go up on steroids. The infection risk goes up. Hirsutism, what is that? That's hair growth where you don't want it. So it's facial hair growing on steroids. Thinning of bones, osteoporosis, fluid retention, skin fragility, cataracts. I mean, you can fill pages with the side effects of steroids. The side effects of steroids are related to the dose and the duration that you're on that dose. The rule is use the lowest dose that does the job. Antimetabolites, I've listed some of the drugs that we use: azathioprine, methotrexate, mycophenolate, and leflunomide. And they each have their own set of side effects. So with azathioprine or Imuran, low blood counts, that's what a cytopenia is. Lymphoma risk goes up on that drug. Methotrexate has been around for a long time. Our fear of methotrexate is its effect on the liver. It can cause hepatotoxicity. Mycophenolate mofetil, we use that a lot now for kidney disease, but we worry about skin cancers and lymphoma. An annoying side effect is its effect on the stomach, causing diarrhea and some nausea. Leflunomide is approved for rheumatoid arthritis. We'll sometimes use that in lupus. It can cause hypertension. It can cause liver problems as well. And cyclophosphamide, which was the standard of care for kidney disease, we don't like to use at all. It can lower the white blood count, which renders a patient susceptible to infection. It can cause bleeding in the bladder, known as hemorrhagic cystitis. It can cause sterility. It's age-related, but say a 20-year-old who gets a lot of cyclophosphamide might have a 25% risk of sterility. And as you get older, that risk goes up, approaching 50%. It can cause cancer, leukemias, and bladder cancer. So we try to avoid this drug if we can. So here's a case for you. We'll do this in interactive fashion. I'm going to tell you about each of these manifestations that this particular patient has, and I want you to rank the manifestations as if you're the doctor treating this patient. So this is a young female who has arthritis, swollen and painful finger joints, but getting by. In the morning when she wakes up, she's very stiff and has a little bit of trouble with pencils and utensils, but it's kind of tough little person and is getting along. Has pain in the right hip, but to make a long story short, the right hip pain is from osteonecrosis. So she had been on steroids a while back, high doses of steroids, and she developed pain, which on x-ray showed osteonecrosis. Laboratory tests are done on this patient, and she has hematuria, which is red cells in the urine. She didn't know. She has proteinuria, meaning protein in the urine. She has high anti-DNA antibodies and low complement. What does that all add up to? She has inflammation in her kidney. We don't know how much, but we think she has inflammation in her kidney. She has hair loss, alopecia. And then the blood test showed that her platelet count is low, though she's not having any bleeding problems. And she is quite fatigued. So how are you going to rank these? Which is most concerning to you or to the patient? So if you ask the patient's bothered by arthritis, number one, and hair loss, and fatigue, And pain in the right hip. The patient doesn't know from a low platelet count. You don't feel bad if you have a low platelet count. You're at risk of bleeding, but you feel fine. And the patient isn't really aware of, hematuria. So what if the patient has 10 red cells under the microscope? That's like nothing. Or proteinuria. You don't feel kidney disease. But the things you feel and the things you see, that's what patients rank high. But my ranking is a lot different. Here's my ranking. I'm worried about the platelet count because this platelet count was really low. It was like 5,000. So that's dangerous to the patient. That patient could bleed anywhere in the body, including into the brain. I'm worried about the kidney disease. You get one chance with your kidneys. The problem with inflammation in the kidneys is that it heals with a scar. Some things, when inflamed, go back to normal. But the kidneys, those little glomeruli, that little tuft that I showed you, that just kind of shrinks up and goes away. And if enough of those go away, you're facing dialysis. So I kind of agree with you. I'm worried about the low platelet count and the nephritis, and less so about the arthritis, and less so about the hair loss. And fatigue, I'm sympathetic, but it doesn't rank high on the list. And the reason that the pain in the right hip is ranked last, it's not an active, reversible problem. The way you treat that is with pain medicines or maybe even a hip replacement. But I can't give that patient steroids or an immunosuppressive and have the osteonecrosis go away. So how would I treat this patient? Well, I'm most worried about the low platelet count. I would use high doses of steroids, high doses of prednisone. For the kidney disease, I need to know a little bit more. I might do a kidney biopsy. And then we're talking about Cytoxan or Cellcept. Arthritis should respond, as I mentioned before, you treat the most active and hope that everything else falls into line. So arthritis and hair loss and fatigue may improve with my therapies for the low platelet count and for the kidney. And for osteonecrosis, relieve the pain. So once we initiate therapy, what do we follow? We go the old-fashioned way. Talk to the patients. What's happening with symptoms? How is the pain? How is the fatigue? We examine the patient. How is the joint swelling, the arthritis? How is the rash doing? And what's happening with laboratory values? So every time I see a patient, you can pretty much count on blood tests being done and a urine being done. So we look at the cell counts, the kidney function, the antibody levels, the complement levels. And then in studies, we use more formal metrics to follow patients. There are disease activity instruments. One is known as SLEDAI and the other is BILAG, but just in studies. So I say at the bottom, much of this is art and not science, and it is true. I mean, all the insurance companies are trying to turn this or take away the art and introduce various metrics for our patients. So we had to, on arthritis patients, to do joint counts and find out how many swollen counts they have and how many tender joint counts, how many tender joints they have. But I still believe in this being more an art than a science. So I talked about some of the conventional therapies. What if the conventional therapies are not controlling the disease? What are our options? So one is a super high dose of steroids, what we call pulse steroids, and that's the equivalent of about 1,200 milligrams of prednisone. So probably some of you have taken prednisone in this room. You know, hopefully, you know, nothing more than about 5, 10, 20, but maybe up to 60 milligrams. But pulse steroids is 3 days of 1,200 milligrams given intravenously. And we'll typically use that to control kidney disease. Somewhat experimental is bone marrow transplantation. So if lupus is caused by an abnormality of the immune system, zap the immune system with chemotherapy or radiation therapy and let it repopulate with normal cells. It hasn't been that successful and it's not a very safe procedure. There are other chemotherapeutic agents out there and other immunosuppressives. They are called calcineurin inhibitors, or at least one type is a calcineurin inhibitor. An example would be cyclosporin. So some will use that for kidney disease. TNF inhibitors. You've probably seen commercials for TNF inhibitors and you didn't even know what the TNF inhibitor is. And you've seen commercials for Remicade. Enbrel. What else is being advertised these days? Cimzia. These are drugs that were approved for rheumatoid arthritis. And I've used them cautiously in some patients with a lot of arthritis who have lupus. But you have to use them cautiously because some of the TNF inhibitors can actually aggravate lupus. But it is an option. Biologics. What is a biologic? A biologic is a highly targeted therapy. It's a natural product, though synthetically made. So for example, the therapeutic antibodies that we use are biologics. And we had a bit of history-making news in March of 2011, and that was the approval of Benlysta, belimumab, the first drug actually approved ever in lupus via the route of a randomized controlled trial, which Laura will talk about in a little bit. So that's approved for lupus. There are some off-label biologics that you may have heard of, such as Rituxan, also known as rituximab. It's approved for rheumatoid arthritis. We did trials in lupus, but rituximab was not shown to work in those trials. Was it because the drug doesn't work or because of the trial design? And it's probably the latter, the trial design. And abatacept is a drug known as Orencia, approved for rheumatoid arthritis, also in trials in lupus. So there's a lot of activity to develop new therapies in lupus. And those would be the experimental medicines that I have listed at the bottom.